Hey guys, this morning we talked about mechanical ventilation, and I'm using these kind of teaching videos as ways to supplement the learning while you're on the ICU rotation, so let me know how you like them. I wanted to show you this concept about why mechanical ventilation is different than normal breathing. So when we breathe normally, we actually suck air into our lungs. We generate a negative intrapleural pressure, okay? And air enters our lungs in that kind of dynamic fashion where it's sucked in. In mechanical ventilation, it's a game changer because we're actually pushing air into the lungs using positive pressure. So in the diagram to the left, here is our alveolus, and this is a mechanical ventilation breath. You see that the airway pressure is about positive 30 in this scenario. That positive airway pressure is communicated across the lungs such that it actually pushes on the capillaries a little bit, increasing the capillary pressure. Positive 12 shown here, which is higher than normal state, which is closer to 2 or 3. And then the pleural pressure here is read as positive, which in a normal state, usually our pleural pressures are negative. Again, air is sucked into the lungs. The transpulmonary pressure is the difference between the airway pressure 30 and the pleural pressure 10. That's the distending pressure of the lung. That difference here is about 20. When someone's on positive pressure ventilation and they, in addition to getting air blown into their lungs, they take a breath in at the same time, like on a breath over the set rate. So they trigger a breath, and if they're wide awake and take a deep breath, we have to be careful because that positive airway pressure is going to combine with a negative pleural pressure now, such that the transpulmonary pressure is 50. So you can get really, really high tidal volumes, and that can cause volume trauma and lead to some lung damage. Further, we have to be so mindful when patients have ARDS or inflammatory lung processes because the capillaries are already very susceptible to being leaky and leaking proteinaceous fluid. Shown here in the diagram, here's a patient with, let's say, ARDS who has a airway pressure of 30. They take a breath in such that their pleural pressure is negative 20. And on account of that negative breath in, they actually are creating a very high gradient from the capillary to the interstitial space. The gradient here is 28. So fluid, proteinaceous fluid, can leak into the interstitial space and in turn get into the alveoli, leading to non-cardiogenic pulmonary edema. This is why when patients have really severe lung disease and they're on mechanical ventilation, we have to be super mindful of tidal volumes and airway pressures. We know that patients that are sedated and sometimes paralyzed with ARDS do better and have less potentiation of lung injury for this very reason. So hope that video helps you understand a little bit of airway dynamics and how they change under positive pressure breathing.